So, good afternoon and welcome all who are joining us. I'll just wait for the last few people to come in and join. Welcome to what is one of a series of thematic ecosystems we've been doing around the area of cancer. We've been doing these now for some years now, but specifically around cancer and trying to bring the global view in on how different countries and even different continents are looking at the area of cancer prevention. We're hosting this alongside partners from the 4PCAN project, which is funded through the Horizon program. And we're doing this as part of a series in connection with 4PCAN. We've done one of these already, and we'll put a link out for if you're interested in finding out more about those for people to catch up with. But today we're looking at remote provision. And remote provision, but in different ways. How are we dealing with either remote communities, or how are we managing data, etc.? But rather than just focus on Europe, we're trying to extend this to outside of Europe as well. So we're graciously joined by colleagues from Nigeria, where we'll be soon to launch our latest ecosystem of ECH Alliance. Just for those people who don't know anything about the ECH Alliance, we're the Global Health Connector. Been around for about 14 years. With about 1,200 organizations that are members of us, we bring them together in ecosystems like this one, all over the globe. These have been purposefully trying to break down silos in healthcare by matching need and solution, bringing all the stakeholders together in permanent gatherings like this, in person and more recently online, so we can bring in that global view. Why is that? Because if we continue to work with a country focus, with a country lens, we become blind to innovation and expertise from outside. And we can also offer opportunities to share not only our best practice, and boy, we have a lot of best practice to share, but also lessons about some of our failures, because those failures will hopefully stop people making the same failures elsewhere. Because in health, we have a particular problem where we want to reinvent the wheel. And so we're determined as the Global Health Connector to prevent that from happening and to bring where we see best practice together. So we're pleased today to bring this group together to look at rural communities and how we're working with those, whether that's in countries such as Spain or Romania or Croatia, or in Ireland, across the island of Ireland or Northern Ireland, but also in Africa and Nigeria. Because I think what this should be able to give you is an opportunity to connect some dots. If you work in the cancer sphere with colleagues from different countries, colleagues from different continents, and with different backgrounds as well. If you're interested in finding out more about the ECH Alliance, I'll put my details in the chat function. You can contact me directly. If you're interested in making contact with any of the speakers today, I'm sure they're more than pleased to speak to you. That's enough from me. I'm very, very keen to hand over to our colleague, Marius Ganti from Romania, who's going to give us a bit of an outline. But Marius, over to you. What's the scope for today's conversation?
First of all, thank you so much, Andy, for the introduction and also for the opportunity to come together today and to speak about cancer, in particular cancer prevention in the framework of the 4PCAN project and in this global context. I'm the coordinator of the 4PCAN project, and this project is part of the preventable pillar of the cancer mission, and is focusing on the implementation of the European Code Against Cancer. And working in rural settings is part of this approach in the 4PCAN project, because we are looking to legislation, regulations, socioeconomic dimension, disinformation. So basically, we are trying to cover all the aspects from macro level, meso level, going to micro level, actually at the individual level, family, community, and so on. And in the 4PCAN project, we are working around the European Code Against Cancer. IARC is one of the partners, and IARC is in charge with the development of the 5th edition now of the European Code Against Cancer. In the project, we implement a living lab in Romania, in a small village in the center of Romania. And we choose actually to start our activities where actually is the most difficult to start. And rural areas are so relevant, not for my home country, for Romania, but are relevant for Europe. 50% of people are actually living in rural areas. The access to healthcare, not mentioned prevention, it's a challenge for the people living in these areas. On the other side, it's very difficult for the people to have access to the right information at the right time when it comes to cancer prevention and European Code Against Cancer. Was a challenge for us in implementing the living lab because nobody did that before. So we had to to test and to learn and to adapt and so on and so forth. And we are actually very happy to say that now, after almost 2 years of implementation of the living lab, we are in a position, and this was very clear from last week activities in the living lab in this rural village, that we are now in the position to expand our activities to other villages. In other words, we are now demonstrating the feasibility of the model for other villages. Very important is that using social sciences and in particular social and personal network analysis, and my colleagues in charge of this are in the audience today, we have been very fast able to understand the people living in this community, the community overall, and of course the local authorities and local influencers. And we didn't went to organize town halls or meetings, or we did not enter the community, aiming to present the European Code Against Cancer recommendation without having this data about the social dimension, social infrastructure in this community. And this is very critical. You mentioned the data aspect, Andy, at the beginning. It's really important to generate data. And these kind of data are so important. And I'll give you just one example. Is the name is European Code Against Cancer, but cancer implies a very high level of fatalism and stigma. And we try, based on this data, to find a new way to start the conversation with the people in normal, regular citizens, to start speaking about cancer without paying so much attention to the word cancer. And we basically implemented a campaign called Code for Life. So it's not, we replaced European Code Against Cancer with a new formulation, Code for Life. And we basically touch all the recommendation, but avoiding to put from the beginning the word cancer and all the negative aspects around this. Another dimension is this real co-creation with the citizens, and I mentioned the way our colleagues are capturing what is relevant for the citizens using advanced social sciences methods. But I remember that we went for the first town hall meeting with the citizens, organized with the local mayor and the local committee, and traditional way of presenting the European Code Against Cancer is to start telling people that they should quit smoking, quit drinking alcohol, and so on and so forth. But we did something different. And we said, okay, our 12 recommendations in the European Code Against Cancer, what are the most relevant for you? And please choose 3 recommendations, and they choose nutrition, physical activity, and obesity. And we actually started the co-creation process around the 3 topics with the citizens. We actually build the trust between us as a research group and the community. And then for us, it was much easier to come with the other risk factors, and currently we are actually covering all the risk, all the recommendation of the European Code Against Cancer, I think in a more efficient way in less than 2 years. And I would like just to add maybe one dimension here. With working with our colleagues, we use a methodology called NetMap to understand the full landscape of the stakeholders at European, national, and regional and local level, stakeholders relevant for the cancer primary prevention. But it wasn't just a mapping exercise, but we understood very well the connections between different types of stakeholders, their influence, the coordination, financial ties, and so on. And for us, looking at this map was very, very clear that local authorities could play a really important role when it comes to cancer primary prevention, but usually they are not involved in the current way the cancer primary prevention activities are implemented. And we use this very actionable information in implementing our campaigns, and the most relevant is the Health Festival we organized last week. This, but probably we'll have the chance to enter into more details in the Q&A session. So thank you, Andy.
Thank you very much for that, and excellent timekeeping. One which we'll be seeing repeated. It's got a special watch on, see, but excellent timekeeping and good to see. Hopefully that gives us time for any questions and comments afterwards. Hopefully my audio is a little bit louder now because I was conscious a bit quiet before. It's because I've got such a quiet guy. But without further ado, I'm going to go on to our next speaker. But before I do, one of the things I'd like to highlight is one of the things we're looking to do in collaboration with colleagues on the call here today is later on, this could be of interest for you if you're keen on finding out more, we're going to be hosting our first ever global cancer ecosystem. And that's going to be taking place later in the year on October the 7th. So we'll give you some details about that later on. But without further ado, I'd like to move on to our next speaker, please. And welcome, please, Andre, please. The floor is yours. Thank you for that, Marius.
I'm Andrea. I'm a physical therapist from Spain. I have been working with the National Association Against Cancer for a few years. And when I'm thinking in prevention of cancer in remote areas, for me it's very important to differentiate two topics. The first part is the kind of prevention we want to make, because for me it's different that we address primary prevention in healthy population. We are trying to aim awareness in very young people, like in schools, in high schools. And then when we are talking about routinary screenings, we are trying to raise awareness in older population. This is made mainly in our country by a part of the healthcare system and from national associations against cancer. There are several of them that are trying to raise awareness in the rural, in remote areas, and in the huge urban areas. When we are talking about secondary prevention, I think we should think of the kind of patient we are going to have, because secondary prevention is from people that have already had a cancer, and it's different because they usually want to get the information. They are looking for them. So our job there is not so much to raise awareness in general as to specifically provide the right information that they are looking for. In my experience, or my area of expertise is raising awareness in the huge strength of prevention of strength and aerobic training. We now know, because there's a huge scientific basis, that if we make a patient who has already had cancer, we implement healthier health habits, and we specifically make them train strength and aerobic training, we can lower the recurrence by 40%. And I think that's a huge number to give them, and a huge hope, because it's not just that they have a fewer recurrency in cancer, but also that they can manage better the sequence of the other treatments, as chemo, radiation, or hormonal therapy. So for me, that's a thing to think about. And then when we want to implement it in remote areas, I think it's important that we look at the kind of demographics that we have there, and the specifics of the population, because here in Spain, around 50% of the people live in rural areas. But if you look at my community in particular, it goes higher as 35%. So for us, it's more important than for other parts of Spain. And that has to have to be taken into account. And then we have to look at the specifics of the behavior or the social behavior that we have in the area. For example, in Spain, as general, we have the Mediterranean diet, but there's some parts of my community that the intake of red meat is very high because it's very traditional, and they had higher risk of colon cancer. So for that specific population, we have to have a different primary prevention and a different secondary prevention. And I think that's very important to look at, not as a global, but as a specific. We can have a huge skeleton, but when you try to do everything the same with different population, in the gaps, they follow the people. So they follow the people. So I think we should be specific about that. When we want to talk about the tools we can use in remote areas, my association provides coverage from my village and from other smaller ones, and we are using internet as the greatest tool we can have to reach the population. Why? Because we know almost everyone. It's estimated that globally 70% of the population have a mobile phone. Probably here, I don't have the data, but probably here in Spain is somewhat higher. So we can use that to reach the people. Right now, about 40% of the people, when they have a health issue, they go to Google. And if they feel like the Google is telling them there's something wrong, I say Google, but you can use whatever searcher you want. They call the doctor. And that's not a really great tool, but it's shown that they are looking for that kind of advice online. So what we do is we try to provide high quality information from sources that are recognized by the government, by scientific councils, so they can access to the information in their homes when they need to, and they can watch or revisit the information. That is shown by science. That is the best way that people receive the information. Video that they can watch when they want. They can stop if they have to do something, and they can go through it again if they need to. And it has been shown that has increased knowledge for the population, and self-efficacy, and it has a huge impact in behavioral modification and intention. So if we are looking at a huge wider ways to reach the people, I think videos, and in my experience, I don't do it just by videos, they lack of certain proximity that the patient needs, especially in secondary prevention. So we apply it with patient navigation by a healthcare provider. It can be a psychologist, it can be a nurse, it can be a physical therapist or a doctor, but they can talk about their personal doubts. They can go through the information again if something is not clear. And in our experience, we do it as a group. So we bring the social and communal part to the equation. We make groups mixed in presence, and some are in remote, and they can listen to the other people question. They can raise their worries in the group, and they can hear other persons say they are worried about that too, and that calms them. They can share the experience, and then we start with prevention, and they will go to practical approach, and they start doing exercise with us. If they don't have materials at home, we do it with their own weight, or we adapt it with water bottles. If they don't have a TheraBand, we do it with the thighs. We try to adapt everything, but we look at them, we correct them. We ask each day, how are you doing? How are you feeling today? And they feel like they have the time and the group to do the exercise. So for us, that's a good way to make, in this case, secondary prevention in the population in rural areas and in remote areas that are difficult to reach. Thank you very much for the time and the space.
Thank you very much. And again, very, very pleased. Our speakers are keeping it to time. Great input there. And I think one of the key themes there is, as we all know, the risk of using things like Google for health searches. And as many people have commented on in the past, there seems to be an angle with Google, whatever symptoms you put in, usually there's some point along that search that will come out with the words cancer. So there's a lot of calls for better access to information. We've seen that with YouTube Health and other colleagues. So that's interesting what you say there, Andrea. So that's very much an overview there in terms of information. Carlo, I'd like to introduce what you're up to in Croatia, please, and give us an angle there. What you think, what's happening in terms of remote provision there within Croatia?
Can you see the slides?
We can.
Yeah, okay. So let's segue into how we can use this information to develop AI tools, because AI tools are quite important, especially in remote areas where we lack personnel, healthcare providers. And if they reduce the workload of healthcare providers, they can really improve patient care. So my name is Karl Pintaric. I'm a medical doctor in Croatian Institute of Public Health. Even though my official job title is medical doctor, I mostly work with everything data engineering, data science, data analysis. So today I will actually talk about an AI innovation challenge in oncology that we held this year, organized by AI for Health Consortium. So let me tell you first, what is the AI for Health Consortium? It's actually an EDIC, so it's an European Digital Innovation Hub that, so it's part of the large European network of similar hubs. In Croatia, we have 4 such hubs, and we specifically focus in AI in healthcare. So this consortium combines, has a lot of partners, 15 to be exact. You can see them on the slides. The slide here, it encompasses from everything from academia, public administration, tech companies, and hospitals and healthcare. So basically, our main mission is to accelerate the safe and effective integration of AI in healthcare, which will then improve patient care, especially using telemedicine, reducing the workload of healthcare workers, and basically want to strengthen the healthcare sector and improve patient care by doing this. And we provide several services to innovators, startups, SMEs, so small media enterprises, to foster development of such tools, AI tools specifically in healthcare. So for instance, very important, we provide testing before investing in clinical settings by our clinical partners, so they can see if their product is clinically useful. And also we provide data access. So for instance, the Croatian Institute of Public Health is very important because it plays a health data access body role in future as part of the European health data space. And after the product has been tested, validated, we help them find investors and apply to calls, and also collaborate and connect with other organizations in the networks. Now, I'll talk today about the challenges that we organized. So this year was a very important challenge, and that was the mammography lesion detection challenge, where we had teams build specific AI tools that could help radiologists to diagnose cancer on screening mammograms. Last year, we had an early hospitalization challenge, which went very well. And you can see on this slide, we also do other activities such as participate in policy shaping and have a lot of collaborators and partners. So what you ask, what is actually the role of an innovation challenge? Basically, it motivates people to initiate innovation. It raises awareness about a real world problem. So early cancer detection, for instance, and also it connects people from different domains. So technology experts, healthcare workers, and business development experts, they work together to solve a problem, a real world problem. So this year we chose a very important problem, and that is detection of breast cancer from mammographic images. You all know that it's the most common cancer of women, around 400,000 cases yearly, and 100,000 people, women die of this cancer. And screening programs, early detection is quite important because it increases survival substantially, because even 80%, 85% survival on stage 1, which gets reduced to 35% on stage 4. And that's why early detection is quite important, especially screening programs, which Croatia has a very good one. It starts from age 50 to all the way to age 70 in women. They got called to do mammography exams. Now, usually those mammographic images are examined by 2 radiologists. A single radiologist provides some specificity, around 75%, actually sensitivity, and some specificity, and 2 or more radiologists would increase the sensitivity. So that's why AI is such an important tool, because maybe it could replace one of those radiologists, or it could even further increase the sensitivity of cancer detection, because even undetected cases, but also false positives, raise the cost of the healthcare system. Also, research has been continuously showing that AI can match the sensitivity of a single radiologist and even outperform it. So, and after we defined the problem in the challenge, we had to do an advertising campaign so challengers apply, and we did a selection after this because we had limited resources to train the models. And one of the most important aspects of an AI challenge is, of course, acquiring the right data to train the model. So it has to be quality data and a lot of it. So we at the Croatian Institute of Public Health, as a future health data access body, we gathered mammography images data, we processed it, anonymized it, and provided secure processing environments to challengers, which will be part of the European health data space. So this is planned that researchers, SMEs, will have access to sensitive medical data in the future using those secure processing environments, which are enclosed computers which do not have access to the internet. Now, the challenge started in February, lasted 2 months. And in those 2 months, the challengers did an amazing job creating models which could be already clinically piloted in the clinical settings. So we had 34 teams applying, and we selected 14 of them based on their expertise and diversity of team members. So the most important aspects of this challenge was that the challengers created models that could classify cases based on a clinical relevant score. Then this is the BIRAS score we chose. And it also had their model had to detect those lesions, because if you just give a radiologist BIRAS score without showing them what lesion it gave this score, they won't use this tool at all. So we had most points given for those 2 tasks, and also they had to do an interpretable model. So the model had to give reasoning why it gives such BIRAS scores, and also they had to prototype a user interface during this challenge. And the scores were amazing for such a short time span. In 2 months, they managed to match basically the scores in the literature. So, and one of those prototype application that was developed is shown here on the slide. So this is one of the winning teams MVP, so a prototype app, which was developed in 2 months. And you can see on this slide, it could be already clinically useful by showing BIRAS scores, by showing the confidence scores, by classifying lesions, whether it's a mass or classification, and by giving a recommendation. So this could maybe in the future, after it's being tested, validated, help improve patient care by reducing the workload of radiologists, by helping hospitals with limited healthcare workers and such. So these are our winning teams, and we learned that during this challenge that even in such short time span, if you have good people, good innovators, you can do really amazing things. And we managed to connect all the healthcare all the healthcare. So the hospitals, academia, and everyone participated in this challenge. So thank you. That's it. That's our team.
Thank you, Kano, for that. Very, very informative and very interesting. I think I always when I hear about challenges like this, I always ask some sneaky questions because I can, and my microphone's open and yours isn't. So the question I've got for you is this: how can people we've got on the call who are listening to this learn from this and understand a bit more? Please, if you could, perhaps with my colleagues who are on the call with Adriana, perhaps share with, if there's a website they can go to, or if there's a place to kind of, what I'm really keen is how we can perhaps share this with colleagues. So I know I can see on the call, we've got colleagues, we've got George Margelis from Australia on the call. We've got a lot of people who are ringing in from colleagues from our ecosystems across Africa, from Nigeria, hello to all those people as well, but also across Europe. How can they get and collaborate with this? Because this is great in Croatia, okay? And I'm thinking if that's a model for excellence, how can we then share that wider? I mean, I can obviously offer, because you're one of our ecosystems there, and one of many of the digital innovation hubs in our network of ecosystems, we can share that via our newsletter. But are you open for other people to get involved outside of Croatia?
Exactly. Not only that, we could also share, if anyone is interested, to perhaps clinically test all the products that our SMEs are developing. So there's also a possibility. I know, in fact, in Croatia, some startups do clinical validation in Africa. So we could also connect in this way. So we could provide startups that could then help other remote areas develop tools specifically designed for certain populations.
Excellent. So I'm just saying, in our audience, there'll be people there I'm sure will be interested to find out more. Just by way of a prompt, because I'll get told off if I forget. If you do have a question, please raise your hand. I'm sure there's a way we can get a question to the participants here. I think there's already one or two. We'll try and weed some of these questions out to ask when we get through some more of our speakers. But you touched on the very important area of data. Now, if there's one person on this call who's very interested in the field of data, it's our next speaker, Professor Mark Lawler. Mark, I know you're keen to tell us, you're certainly working in the area of data, and I'm very keen to hear from you now.
Thanks very much indeed, Andy, and really enjoyed being on the session here today. Really interesting. So what I'm going to do is, I'm Mark Lawler, I'm Professor of Digital Health at Queen's University Belfast. I'm also chair of the International Cancer Benchmarking Partnership, where we look, as Andy said, at data from different countries and compare and contrast them and look to see, can we learn lessons from one country that may help another country in relation to achieving better cancer outcomes. And what I want to do is really focus on this area of remote areas and looking at ways in which we can address particularly cancer inequalities, which is something I've worked on for over a decade. And one of the things I want you to get out of this is the importance of data in informing cancer policy. And there's two sort of aspects I'm going to talk about. One is in relation to how we collect data on cancer inequalities. And I'm very fortunate to be the scientific lead of a European Cancer Organization initiative called the European Cancer Pulse. And what we do with the European Cancer Pulse is we collect data in relation to inequalities. And at the moment, it's simply within Europe, but we'd certainly be very happy to explore looking at it beyond Europe as well, because we think it's certainly a very useful tool that we can have data coming to one place that indicates various different inequalities. And by comparing between different countries, we can use that information then to help improve outcomes for cancer patients, which is what we're all here for. So if you look at the European Cancer Pulse, we collect large amounts of data on different countries, and we use that to then inform data strategy. So for example, we produce country reports. We've produced 12 so far from different countries in Europe, and we've launched them in country. So in the particular countries that we've identified particular inequalities, and we launched them in collaboration with the Department of Health. And the reason why we do it in country is really important. It's to make sure that something is done, so that it's not just a piece of paper that says, these are the challenges you face in your particular country, but we're not going to do anything about it. And it's been really successful. The first country we launched in was in Greece. We did 12 of them in 2024. And that prompted then the government of Greece and the Department of Health to talk about delivering a national cancer control plan and also enhancing cancer screening. When we did it in Bulgaria, the response was in relation to looking at universal HPV vaccination. When we did it in Ireland, I highlighted some cancer inequalities between the haves and the have-nots, approximately a 9% difference. When we did it in France, it highlighted issues in relation to breast cancer screening. When we did it in the UK, it was in relation to the cancer workforce. So you can see there in each situation, we focused on a particular form of data and used that to drive potential change. And it's been really effective at highlighting the situations. A lot of this was picked up by the media as well, but most importantly, picked up by the respective departments of health, who've then used that to actually drive policy change. And the second area I want to talk about is the Code of Cancer Practice. Again, it's a European code at the moment, but again, very happy to talk with colleagues who are on the call and part of the network, or the alliance, I should say, because we again see this could be certainly applied outside Europe. And essentially, we started this program about we started pre-COVID, and we wanted to look at what should cancer patients or people who are susceptible to developing cancer expect from their cancer health system. So it's moving slightly further along the pathway than was spoken about earlier, but very much emphasizes the importance of looking at, what should we expect from our health system. And you can see there the European Code of Cancer Practice is highlighted on the right-hand side. And what's pretty important, I just want to highlight a few things just in the interest of time. One, the importance of information. If we don't have accurate information, and Andy talked about this at the very start, and also Andrea talked about it, we want reliable information that people can actually use. But also we want the input of research. We also want to make sure that we're looking at, as more people survive cancer, how do we support cancer survivorship? And you can see that the last four themes in the Code of Cancer Practice are all about survivorship and living with and beyond cancer. We've also now recently adapted this to the rural and coastal settings, because as we've heard at the very start, we see big challenges in rural settings and coastal settings in relation to poorer outcomes. And we want to try and explain that some of it is to do with access to healthcare, but it's not just the only situation. And I've put in a number of publications there at the bottom of the page. Obviously, happy for this slide to share, both showing the European Cancer Pulse and what we've done with it, but also highlighting both the Code of Cancer Practice, but also how we've looked at implementing it in rural settings. And one of the things we're doing now, we feel it's been 5 years since we launched the original Code of Cancer Practice. We're now in the process of updating it, obviously in the context of COVID, but also putting it more with that rural and coastal lens to it. And so hopefully I've sort of shown you that, using data as well as understanding cancer, we can also use it to actually influence cancer policy. And we'll be very keen on exploring in more detail with the membership how we can expand that beyond the European lens. Thank you very much, Andy.
For that, Mark, and some interesting links there. I think we'll post some of those in the chat for people to have a look at as well, where we can get those. So we can put those in the fact we'll share those with the rest of the audience. Just want to ask you, and if I can then also ask perhaps Marius and Andrea as well, who do you think's getting this right on the data piece? I mean, you mentioned some countries. Who's nailing this outside of Ireland, or that you think we need to learn more about what they're doing? Yeah, well, I mean, obviously Estonia would be the digital trailblazers in Europe from a European perspective in relation to the overall use of data in healthcare. But if you look, I mean, I very much admire the Danish system, because if you look at Denmark in the year 2000, Denmark had the worst cancer outcomes in Europe and the highest incidence of cancer in Europe.
And what they did was they then collected data to inform what they would do about it. They found, for example, radiotherapy, they had a very low provision in terms of radiotherapy machines. Breast cancer services weren't centralized. A number of things that, again, they found. And then each of those, then they looked to address. For example, they were seeing very poor outcomes in relation to diagnosis happening in emergency, accident emergency or ER, rather than in primary care. And that's led to the situation now. If you look at recent data from Denmark, you see the biggest improvement in relation to cancer outcomes in Europe. They're not number one in terms of the best of cancer outcomes, but certainly they've improved exponentially. And so that's sort of an example of using data, and using that data allows you to show what can be done. So it isn't sort of a situation that once you're in a situation that may not be so good that you can't change that. And I think that's a really important message to get across. By using data and implementing changes in policy where appropriate, you can actually improve your cancer outcomes.
Okay, that's helpful. Marius, I'll come to you, Danadi, in a minute, but Marius, please, who's getting this right?
So from my perspective, I think, it's really important that data and in general technology should somehow contribute to decrease the inequalities. So, and I'm a bit scared about the European health data space implementation. Because of course it should go through national legislation, national parliaments and so on. But the problem is, and now I'm trying to answer your question, the problem is with the countries that have no registries in place, that are not famous, for having the right data governance, data structures, infrastructures, and so on. And my concern is that if the European health data space and big data initiatives will exclusively rely on the same governmental bodies or public institutions who actually failed all the time in this area, I think this will increase the inequalities even more. So what I'm trying to say is to look beyond public entities, beyond governments, and to find other ways actually for the citizens and patients to really contribute with their data in this new ecosystem of data that is now building across Europe.
Okay. Interesting.
Andy, just to sort of in terms of sort of pushing for the country that I work in, Northern Ireland. So as of 2 weeks ago, everybody, so the 1.8 million population of Northern Ireland, all have their health data on their phone, their own health data. So that's been I would call it a Thomas Edison moment in relation to essentially it's an innovation moment that's really going to change healthcare in Northern Ireland as we know it.
Well, that doesn't surprise me. I've seen you mention that before, Mark, and I'm surprised you haven't done so already. But Mark also gets commission for every person that moves to Northern Ireland as well. He's part of the inward investment program for Northern Ireland and very successful at it. I think joking aside, it's a very, very crucial tool, because I think, even the small countries can do this, and they can do it with political will, and trust often go hand in hand. And you mentioned about the European health data space. Obviously, it's very, very interesting for colleagues across Europe. I've always said it keeps half of Europe awake at night worrying about it, sends the other half to sleep. So it's one of those things. I think we can use this, but I think data in patients' hands is the key. I'm keen to also now, if I can, look outside of Europe, because there are so many other programs happening outside of Europe that we could pick many of them. And I wanted to come to one of our partners in Nigeria with the Nigerian Cancer Society Association, because not just by accident, we're going to be launching our latest ecosystem in Nigeria in July, on July the 17th, in Abuja, taking place during the Africa Health Symposium. There'll be details winging their way down the screen there now, if you want to take part in that remotely, or even in person. But I'm pleased also to welcome Professor Danali. Would you please introduce yourself and tell us what's happening around rural provision in Nigeria? Because Nigeria is, for those people who've never been, is huge. as a country. Slightly more people than in Northern Ireland. So please, the floor is yours.
Thank you, Andy, and thank you, to all the speakers and participants here. President, please, can you hear me, and can you also see
I can see and hear you. Perfect.
Oh, thank you very much. So I am Professor Bojude. I am based actually in Gombe in northern Nigeria, but I'm also the Secretary General of the Nigerian Cancer Society. I'm Professor of Community Oncology. So cancer prevention and care in rural areas, in communities, is actually where my interest is. But I practice in Federal Teaching Hospital Gombe as a consultant clinical and radiation oncologist. I'm also the director of Institute of Health Sciences. This is essentially like a training school for health workers. At the Nigerian Cancer Society, these are our strategies, but I might say when you talk about cancer prevention, and especially remote areas in sub-Saharan Africa, it tends to be a bit slightly different from Western countries. I was in Edinburgh, Scotland for almost 4 years, and I attend conferences and meetings, and I go to local areas, and definitely the places are actually different, especially where you have a lot of access, road access, telecommunication, water, electricity, and everything is there. But in Africa, it's slightly different. Those things are actually lacking. So remote areas, you have lack of access. There are no facilities, etc. Transportation, all those things are actually lacking, as well as hospitals and doctors and other healthcare workers. And of course, when we talk about prevention, essentially lifestyle modification, screening, vaccination, and the rest. But at the Nigerian Cancer Society, especially regarding prevention of cancer in remote areas or rural areas, the Nigerian Cancer Society has some strategies, especially with previous leadership as well as current leadership. We actually give emphasis on state and local branches or local councils. We felt that the prevention and all the information should be cascaded down to the remote areas, to local councils. Some local councils are actually in remote areas, some are in urban areas, and some are in semi-urban areas. And so by the time you have branches everywhere, communicated, we have common platforms like WhatsApp groups, Facebook, and so many things that we can actually communicate with them, and we know what they're doing, we can advise them, we have meetings with them. And so all these things, the Nigerian Cancer Society actually reaches the various remote areas. We were able to successfully bring survivors on board, and these survivors are in all communities. We have their leaders in various states, in various regions, but they are able to reach their actually survivors in various communities and remote areas in Nigeria. There is a youth coalition, YOCAC, and these youths are actually doing a marvelous job reaching out to all their communities. They have their branches all across Nigeria, doing a lot, trying to support cancer prevention, awareness creation, screening, and a lot of advocacy that they are doing in the communities, including remote areas. We're doing a lot of media engagement. We have a grant from Pathfinder and Bill Gates, and that is helping us to actually talk to media people, to reach out to people in different communities. Especially we use information, education, and communication materials regarding cancer prevention in local languages across Nigeria. We've engaged civil societies across Nigeria, including community-based organizations, through various activities, especially the World Cancer Day, International Cancer Week, which is coming up in October. And so we're doing a lot to actually reach communities or remote communities. Currently, the Nigerian Cancer Society has engaged in raising 10 billion naira cancer intervention fund to actually support most of these activities that we're doing, including research. And so when we talk about prevention, I've already given some small highlights about primary prevention, health style modification, a lot of information about tobacco control, sexuality, male circumcision. This is a small adapted from actually WHO guideline, specifically regarding cervical cancer and secondary prevention. But this is a study from a systematic review I conducted myself as part of my doctoral research at the University of Edinburgh. And what I found, again, regarding communities in sub-Saharan Africa, I was able to look at almost 26,000 studies, but I ended up with about 49 studies that are actually almost nearly equally spread across the whole of sub-Saharan Africa. And these are some of the facilitators and barriers that I found regarding especially implementation of community-based screening in sub-Saharan Africa. So I grouped them into demand for screening, access to screening, and sustainability of screening. And when you look at the facilitators, you can see about patient and peer education, peer group support, community buy-in. These are things that you actually need, especially when you are dealing with remote areas or communities in sub-Saharan Africa. You need to visit their homes. You need to do workplace visit and do some comics, some grammar. We need a lot of music and drama. That actually tend to draw people's attention, especially in Africa. And when you talk about the barriers for demand for screening, is of course there will be lack of, we have lack of awareness. Awareness is very low level of knowledge, misconceptions, a lot of fatalistic views in Africa. And then when you look at access, we talk about conducting community outreach, which we've done a lot, mobile clinic and team doing peer navigation, village-based programs, and trying to integrate services, especially at the level of the community. That helps a lot regarding access. But we hope a lot of, some of the barriers, again, are distance, cost of transportation, and other issues that actually come up. But again, there are a lot of efforts that are done to actually overcome them. And again, sustainability of screening. We do partnerships. We do same-day treat and see and treat services, subsidized free services that are offered. But of course, we try to do a lot of advocacy to get the political will from our leaders to actually do that. These are some of the facilitators. And when you look at, talk about the barriers to sustainability of screening, then of course, earlier mentioned inadequate manpower, lack of equipment, a lot of laws to follow up, and of course, lack of national screening program. But in Nigeria, we now have a screening program. In fact, recently there was a launching, or I can say commissioning, of the task force for controlling cervical cancer, and the National Institute of Cancer Research and Treatment, NICRAT, is actually doing a lot to actually see that. And further, there is a recent publication that myself and my colleagues that actually published recently regarding cervical screening fieldwork in rural and complete prone settings in northeastern Nigeria. And these are some of the experiences, or I can say reflections, challenges, and lessons learned that we actually got from conducting some of these cancer prevention activities in complete prone settings in northeastern Nigeria. And overall, some of the main challenges that we have found is that whenever you are going into the community, you have to ensure researcher and participant safety. I'm talking about this because some of our remote communities, you tend to have, especially the complete prone settings or in northeastern Nigeria, then there is issue of especially insecurity. You have a lot of views of mistrust and fear whenever there is something like a foreign or something new, or maybe a government or even an international organization coming into those communities. And these are some of the peculiarities that we have in especially northeastern Nigeria or in sub-Saharan Africa. And so some of the challenges mainly that we found are to ensure researcher, or let me say a health worker safety, and as well, whenever you are going to community, you have to actually choose it very well and try to do whatever you can do to get access, especially through gatekeepers. And there are a lot of strategies that one can do to actually have a very successful entry into communities. And then, of course, whenever you are able to recruit participants for either screening or education, although we reach a lot of them through media and the rest, but if you have to really go into the community, you have to actually do that and gain trust. Building trust is actually very important. And also, especially if you're taking data
Oh, I think we lost your audio there. We'll see if we can reconnect you. But you've touched on a very important topic, which is trust. And I think that's a very key, vital figure here.
Then you have to make sure that autonomous, and there are a lot of actually carried out to make sure that those information here that so thank you very much. I think I don't have to say much. I've already
that's been very, very helpful. Very, very helpful. Just on that issue of trust, I know we've got some chance. How can we get trust built in? I'm going to ask all our panelists this, but how is trust gained in settings like you've just described?
My network is cutting. Please come again.
How do we build trust? What one key thing is there to build trust around this area in rural communities?
So building trust in my own, especially from my experience, comes in from the way you actually approach the community. How who do you actually introduces you to that community? How do you actually enter the community, especially in terms of dressing? Do you actually look trustworthy and the rest? Those things are very important.
Okay, that's very interesting. Andrea, I'm going to come to you next, if possible. How do you think we can work on the area, both of trust, but also how do you think we can ensure, where can we collaborate together from not just from Europe, but Europe across to Africa? Andrea.
I think we can share the strategies. Here in Spain, I think a few organizations just reached to they build it like it's a federal thing. So they have high value inside the small communities, and they build it exponentially nationally, but they are very in touch with the needs of the community, because here health is divided in the small areas. So if you don't see what are the needs of the specific community, you cannot build it up. And I think that's what he was saying, Professor Damo of Professor. And I think we can share where we fail, like you said earlier, so we can learn from each other's mistakes.
Okay, thank you for that. Mark, any input? You're on mute, Mark.
Maris and myself are both here at the World Cancer Series, the Economist World Cancer Series in Brussels, and exactly the same conversation in relation to trust came up. And I think the key thing, and Maris will talk to this as well, because he has some really good examples, is the whole area of co-creation. And so that actually it's not just cooperation or collaboration, it's co-creation, and looking at working with different communities from the bottom up, as was said by Andrea. I think that's really important, but it's interesting just in two completely different conferences, that the same issues are sort of surfacing. And certainly trust was one that was talked about quite a lot in a number of sessions in relation to trust in relation to particularly cancer screening, and the lack of trust sometimes that's shown in sort of national governments in relation to cancer screening is what contributes sometimes to very low screening rates, for example.
Interesting. Marius? Interesting.
Yes, probably the most important part is to be able to listen to the citizens and the communities, and to learn about them, to understand what are their needs. And just to give you one example, you might not immediately consider, when you implement cancer primary prevention campaigns around European Code Against Cancer, you might not consider from the beginning to involve in your multidisciplinary team a cardiologist. And why we are actually doing this in our project is because a lot of people in the community have cardiovascular diseases or risk factors, and they don't have access to basic ECG or cardiovascular checks and so on and so forth. And for us, it was really important to address these needs of the individuals in order to build a trust and to make them pay attention to the other messages we're actually sending to them, part of our activities.
Thank you. Now then, I know we said we're going to finish on time. I think we've had a fantastic input from multiple countries today. We've certainly learned about the overarching approach with the 4P CAM project from Marius, and I think the approaches we see in Romania, as well as the idea about some of the cancer issues as well. I think we've seen some fantastic practical examples from Andrea from Spain, which I think are quite useful to be, again, exported outwards and shared wider. I think the approach that we've seen from Mark, I mean, you know, the idea of putting all your data for your entire population on the phone for everyone to access is a game changer. And if you don't believe it, ask the people who use it and what annoys them about it, because they've got access to their own data in a way that they've never had before. And then I think we've seen then the challenge-led approach in Croatia, which is shareable, and I think an opportunity there to collaborate. And then lastly, I think a fantastic approach in terms of addressing very rural communities that lack connectivity, but still have that same need for communication. And I think that's fantastic to see from Nigeria. Yet again, we've seen a way forward where we can share best practice from not just across Europe, but from Africa as well. If you're interested in getting involved with that Nigerian ecosystem, as I said, that's going to be taking place July the 17th in Abuja. I'll be pleased to meet you in person there, hopefully, and the Nigerian Cancer Society in person as well, who are co-hosting this. I'd like to thank all the speakers today for taking part. And if you're interested in finding out about any of the initiatives we've discussed today, whether it's the approach from the data approach and the cancer pulse that Mark talked about, or the approaches from Spain from Andrea or Carlo, or indeed Nigeria from Professor Donati, please get in touch and we're there to connect some dots. Thank you very much.